Hi, I'm going to talk about quadrupling inhaled glucocorticoid dose to abort asthma exacerbation. Asthma is one of the most common chronic diseases with an estimated 300 million people affected worldwide. Acute exacerbations of asthma are frightening for patients, cause considerable illness or death, and account for a large proportion of the overall costs related to asthma. Asthmatic exacerbations are episodes of worsening of the patient's baseline situation that require modification in treatment. They must be clinically identified by change in symptoms or in relief medication or in lung function with respect to the daily variation of a particular patient.
Roper St. Francis Healthcare's House Calls TV.
Asthma affects millions of Americans, and it's typically controlled with medication. But sometimes an asthma attack will strike. Dr. John Ramey explains what to do when your inhaler doesn't work.
If they can't get it relieved with their rescue inhaler, then they need to let someone know. If the patient comes into the office or the emergency room, we can treat them with nebulized medications, which can help. A lot of times these patients need to be on steroid injections or IV steroids to help control their asthma exacerbations.
And don't assume that an asthma diagnosis means you have to suffer through attacks on a regular basis.
If you're using your albuterol, your rescue inhaler, more than twice a week, you really need to see your doctor because that's an indication that you may need to be on a daily medication.
Doctors at Roper St. Francis participate in research and are constantly working to find the medications that best help patients avoid these types of attacks.
Patients' quality of life improves. They're less likely to miss school or work. They're more likely to be able to sleep at night.
For more information, call 402-CARE, and for more House Calls TV, visit us online at RS.
Application in medicine. The objective of the treatment of a crisis is to preserve the life of the patient, reversing airflow obstruction and hypoxemia as quickly as possible, and later establish or revise their therapeutic plan to prevent new crises, which include a temporary quadrupling of the dose of inhaled glucocorticoids when asthma control starts to deteriorate.
IL-13 is a pleiotropic cytokine central to the type 2 response. It is produced by activated T cells, NKT cells, basophils, eosinophils, mast cells, innate type 2 cells, and monocytes, and is elevated in a subpopulation of patients with asthma. IL-13 acts by binding to IL-13R alpha-1, causing heterodimerization of the receptor with IL-4R alpha, and subsequent signaling. It is this signaling that makes IL-13 an important cytokine central to the type 2 inflammation that contributes to many key features of asthma, including mucus production, airway hyperresponsiveness, fibrosis, and IgE synthesis. IL-13 also plays a key role in reduced glucocorticoid receptor binding affinity and blocking glucocorticoid receptor translocation to the nucleus. IL-13 is elevated in patients with glucocorticoid insensitive asthma, correlates with severity of disease, and can also be elevated in patients that have experienced asthma exacerbations. Therefore, IL-13 blockade is an attractive therapeutic approach for the treatment of bronchial asthma.
Pros and cons. Adverse events and serious adverse events relating to established adverse effects of inhaled glucocorticoids were reported during the 14 days after activation of Zone 2 of the self-management plan after a request from the Day Monitoring Committee. Cases of pneumonia were reported for up to 4 weeks after activation of Zone 2.
I'm Dr. Olson. How you doing? Having trouble breathing? Just breathe this in, okay?
Ramon Fargas is a chronic asthmatic.
1 to 4 probably, right? That means he's got pretty bad obstructive disease. Have you ever been intubated before? How many times? 4 times? He has having a severe asthma attack, and he's got a history of asthma. He's been put on a ventilator several times before, so he has the potential to get really sick really quickly. And he's having trouble breathing right now. We're going to put him on a machine that's going to help him breathe and open up his lungs a little bit. Just hang in there. Focus on breathing. You ever been on the CPAP machine? We're going to put you on that now, okay? Is this one of your worst attacks that you've ever had, or you've had worse? You've had worse. All right, that's good, Dad. The worst thing for these guys is when they can't keep up with their own breathing, and we have to put them on a ventilator. We have to sedate them and what's called intubate them, which is put a tube down their throat to help them breathe. And they get a lot of other problems associated with that. Infections from the tube. They lose their ability to breathe on their own. They have to go to the ICU for several days. So it's much better if we can avoid doing that.
But Ramon can barely breathe.
What's his blood pressure?
It's going to be a fight to keep him off the ventilator. But the chest x-ray shows Dr. Olson's suspicions were correct.
He's got a pneumonia. Gnarly looking pneumonia. And he's got cephalization too. It looks like he may have a little bit of component of failure. It looks like you have a pneumonia on the right side of your chest, okay, in addition to the asthma symptoms that you're having. Deep breath. Okay, good. He's sounding a lot better than when he came in. He looks a lot more comfortable than when he came in. So we're going to admit him to probably a monitor setting, probably telemetry or ICU, just to keep an eye on him overnight and make sure he continues to get better.
In Ecuador. In the country, there is not a concrete number of how many persons they suffer this respiratory deficit, but in agreement to the world estimation of which the pathology affects 10%, Ecuador will have a bit more than 1 million affected persons, and according to the pulmonologist Efren Guerrero, more than 50% self-diagnosed.
According to the most recent statistics available from the Center for Disease Control and Prevention, in the United States, over 25 million people have asthma. That's more than double the amount of people who had cancer in the same time frame, and that number is only growing larger. Worldwide, the disease is expected to grow from 300 to some 400 million people by 2025. In the US, it's worse. 1 in every 12. Of the millions of those in the U.S. that are suffering, about a third are children, meaning that 1 in every 10 children suffers with the disease. It is also a disease that discriminates. Females have a higher percentage, and so do non-Caucasians. For non-Hispanic black children, for example, 1 in 6 suffer with asthma. It is with non-Caucasians that the greatest increases have occurred over the past decade as well. In other words, the situation is not getting better. It is a disease that is costly. It strains personal lives, resulting in thousands of dollars of costs per year, most of which could be prevented. It strains hospitals. Like VCU, Virginia Commonwealth University Hospital in Richmond, Virginia, it accounts for nearly 60% of all emergency room visits. Because of the frequent ER visits and emergency services required, asthma puts a significant strain also on insurance companies. It is costly, and not just in terms of dollars. The disease is not just an issue of breathing and lung function. It has significant psychological effects relating to fear-based trauma and disempowerment. It is not so much, therefore, a disease about dying, but one of living. It is costly to the quality of life. That is not to say, though, that people do not die from asthma. Every day, 10 people in the United States die from asthma. It may not be as high a mortality rate as some of the infectious diseases that have ravaged mankind throughout the ages, but it is certainly one of the more prolific. While great organizations and efforts are leading the charge to tackle these other deadly diseases, deaths worldwide from asthma are still about a fourth of that of malaria. According to the World Health Organization, though, sadly, quote, almost all of these deaths are avoidable.
The temporary quadrupling of the dose of glucocorticoids when the control of asthma deteriorates resulted in less severe asthma exacerbation than in a plan in which the dose was not increased.
Inhaled corticosteroids work at many levels in airway disease, such as asthma and chronic obstructive pulmonary disease, or COPD. Within the airways and submucosa, inhaled corticosteroids have effects on structural elements, such as epithelial cells, endothelial cells, smooth muscle, mucous glands, and cells, as well as actions on inflammatory cells, including eosinophils, lymphocytes, mast cells, macrophages, and dendritic cells. Corticosteroids are small hydrophobic molecules that freely cross the plasma membrane. Glucocorticoids bind to the glucocorticoid receptor in the cytoplasm, and this bound complex moves to the nucleus. Within the nucleus, steroid binds to glucocorticoid response elements, activating a DNA binding site. Within the nucleus, steroids enhance the activity of compounds that reduce transcription of inflammatory proteins. The production of inflammatory cytokines, including interleukins 1, 3, 4, 5, and 8, TNF-alpha, and GM-CSF are reduced. Reduction in cyclooxygenase and phospholipase A2 and an increase in lipocortin 1 reduces production of inflammatory prostaglandins and leukotrienes. Nitric oxide synthetase is reduced, and this leads to a reduction in nitric oxide. Steroids reduce endothelial expression of adhesion molecules and cellular activation and migration, so leukocyte chemotaxis is reduced. Steroids increase endonucleases that increase apoptosis of lymphocytes and eosinophils.